Good morning. I just want to do a quick wrap up for our week 2 discussion in imaging class. Once again, I appreciate everybody's responses. You guys were very active on the boards, which is great. People are getting into the discussions and adding their own experience and also looking up research and contributing to that. So that's really awesome. I mean, I think that is going to enhance this course by a lot, and it already has by you guys sharing those things, including both your experience, research, bringing in things from the readings and lectures that we've talked about. A big theme that came up this week, at least from that Dial article, was PT's ability to order imaging and also our ability to make a good differential diagnosis using our clinical examination skills. This has been studied, not extensively, but at least a bit, and really what they found when they've done some of these trials is that PTs can be just as accurate as other healthcare providers in differential diagnosis, in ordering imaging. And patients are just as satisfied, if not more, because we typically spend more time, we educate our patients, all those kinds of things that PTs are good at. And so hopefully that was an eye-opener for some of you guys to feel maybe better about yourself and your profession, that we probably have more knowledge and ability than we sometimes give ourselves credit for, and that's one of the reasons why we have the DPT now, and I commend you guys for going back to get your DPT to kind of give yourself that credential that shows that we are a doctoring profession, we have an ability to make a diagnosis, and in my opinion, I think we would be responsible providers of imaging studies. So, obviously there's some barriers there to ordering imaging. One would be, would the patient get reimbursed for it if it was ordered by a PT? That would be a hurdle to pass. And then would we be sort of stepping on the toes of our physician colleagues? It's possible with that, particularly when we talk about like older physicians that might not be as familiar or working alongside PTs. But I think whatever we can do to better serve our patients in the most efficient manner would be a good thing. Now, if we all did start getting the ability to order imaging, would there be more pressures on us, from our patients that are sometimes pretty demanding of wanting to get imaging studies? Would our liability go up? So those are some things that we kind of have to talk about and wrestle as our profession. If you are interested in this topic and you find you want to get involved or just learn more about it, I'd recommend joining the APTA Orthopedic Section's diagnostic imaging special interest group. So this is definitely a topic they're tackling, in addition to what type of imaging education should be provided to PTs at the entry level. And perhaps if you are going to be able to order images, would you need additional maybe postgraduate education or some sort of competency or certification? So the same things that you guys are bringing up, other folks in the profession, the leaders in the profession have been talking about. And then some other things that came up on the discussion board were just related to lower extremity. We talked about OA, we talked about hip FAI, meniscal tears, and we keep coming back to that many times. The image doesn't necessarily correlate with the patient's symptoms. So that's where we definitely want to go back to our PT bread and butter skills, make sure that we are not just treating what's on that image. We're using our clinical examination to formulate a diagnosis and a treatment plan, taking into account the imaging findings, which for many conditions, the imaging findings play a minor role in the whole experience of pain and function in that patient. So hip OA is a good one, FAI is another, where a lot of people are walking around out there that have imaging findings with little or no symptoms related to those conditions. So continue to kind of question the relevance of the imaging findings when you do see them, and make sure that they do match up with what you're seeing and hearing clinically. So great job again. And then this next week, we're going to talk about upper extremity imaging. And I put up like a small little case scenario for a patient with shoulder pain. So I'll be interested to see what you guys come up with.